Welcome, and thank you for joining us. My name is Dr. Michaeline Friedenberg, and I'm the President and CEO of the Institute of Reproductive Grief Care. I'm joined today by the Institute's Nurse Planner and Healthcare Education Coordinator, Elsa Ahrens, who will be co-hosting and facilitating today's conversation with our featured nurse researchers. For accreditation purposes, we have no relevant financial relationships or conflicts of interest to disclose. We do want to note that one ANCC contact hour is available only to those who are participating live today. We're excited to have professionals from across the country, nurses, social workers, chaplains, bereavement care coordinators, and community leaders participate in this important discussion. Since a number of you are joining us for the first time, I'd like to share a little bit about our organization. The Institute of Reproductive Grief Care is the global expert in evidence-based, trauma-informed reproductive grief care education and training for healthcare professionals, mental health providers, and community leaders. We are at the forefront of creating and circulating impactful, impartial research to better understand how individuals process reproductive loss in order to provide them with the best possible care. Our flagship initiatives include our comprehensive emergency department program and the 5-question reproductive grief screener that will be ready for use next year. Now, before I turn things over to Elsa, I'd actually like to start us off with a quick poll, and I hope that all of you will participate in this. So, as you reflect upon your practice, how confident do you feel supporting patients and their partners through reproductive loss using a comprehensive team-based approach? So take a moment to do that. And so we're asking here how confident you feel delivering compassionate team-based approach. All right. Well, also, I'm going to give them about 30 more seconds and we're going to end the poll. And if I could have you maybe just like give us your response to the results. All right.
Absolutely.
So let's do this now. Let's share those results.
Okay. Let's see. So it looks like a majority are saying they feel somewhat confident or confident seems to be our most prevalent answers, which is great. And our hope really is that by the end of today's webinar, you feel increasingly confident, right? We want you to feel equipped to provide this compassionate care. So regardless of where you are, we're excited that you're here.
Exactly. And to me, like this is not surprising. I know we have a special group that's joined us, so it doesn't surprise me that we have some more in the somewhat confident, in the confident level. But we're going to learn much more. And could you start us off, Elsa, then by introducing our nurse researchers?
Yes, I would be happy to. Thanks, Michaeline. Today, we are so grateful and honored to feature two nurse researchers, Dr. Mattson and Dr. Berry, whose recent peer-reviewed study was published in the Journal of Emergency Nursing, and it examines reproductive grief care education in the emergency department. I believe that we will also have a link in the chat to their study, and we really would encourage all of you to click on that and read it. You should have full access, so highly recommend. Dr. Mattson and Dr. Berry's work directly addresses a significant professional practice gap, and that is that many emergency department nurses and healthcare professionals report limited confidence, guidance, and preparation when they're caring for patients who are experiencing miscarriage and early pregnancy loss. Today's conversation is not just about what they found, which is profound, and I'm excited to share it with you, but it's also, we're going to talk about how this research can really change what happens at the bedside. So let me introduce you to these two fantastic women, and then let's jump in. Dr. Rebecca Mattson is an assistant professor at San Diego State University. Her scholarship focuses on population health, with emphasis on innovative digital approaches to improve patient outcomes through targeted screening, education, and intervention. And her clinical background as a maternal child registered nurse informs her research. She also contributes to advancing compassionate, patient-centered care for individuals experiencing reproductive loss. Dr. Nikki Berry is an assistant professor at St. Martin's University in Washington State, and she is an award-winning nurse researcher specializing in perinatal loss, grief, and bereavement. Her work focuses on reducing emotional trauma for parents through trauma-informed models of care, with particular attention to long-term follow-up after loss. Her research has been published internationally, integrated into perinatal palliative care curricula, and she serves on national committees with organizations including the Institute of Reproductive Grief Care and Perinatal Loss and Infant Death Alliance. So, Dr. Mattson and Dr. Berry, it is truly an honor to have you both with us today.
Thank
Thank
you
you
so
for
much for
having
having
me.
us. We're excited to be here.
So with that, let's jump in. As we start, I really would love to ground our conversation and begin with the professional practice gap that shaped this research and this study. So, Dr. Berry, I'll go to you and would love to hear, in your experience, what are you seeing or what have you seen among nurses and ED clinicians when it comes to caring for patients who are experiencing miscarriage?
Elsa, this is a very timely question, and I would love to share more from the personal side before the research side. I was just on Wednesday having a conversation with one of my colleagues who's a nurse in the emergency department. And as I was talking about this work, she kind of got very awkward and looked at me and said, "What do you do? They have a miscarriage and I don't know what to do. I don't know what to say. I know it's a big deal. I call OB and they say, we're not going to take this patient because they're not appropriate for our unit." And it really resonated with me in my own personal experience as a nurse. I remember the first patient I ever cared for experiencing miscarriage. I was an operating room nurse and it was an ectopic pregnancy. And as I was preparing to bring this patient back to surgery, it suddenly struck me that this wasn't a standard procedure. This was much more than that. And I remember asking the anesthesiologist, have we talked to her? Is she okay? Is she grieving? And the anesthesiologist said, I don't even know what to do. And that set the tone for how we interacted with this patient. And she was very stoic. And so I thought, I don't want to upset her anymore. I don't want to do the wrong thing. And that caused me to be silent and to ignore whatever it was she was going through emotionally, which I'm very much disappointed in myself in that, especially with what I know now, having been in this research. But in my personal experience and talking with other nurses, the consensus is that we don't know what to do. We don't know how to address the emotional aspect of this.
Thank you so much for sharing. There's a lot there, and I'm excited. We're going to kind of flesh out a lot of what you spoke about. But I'm just particularly grateful that you spoke from kind of the lens of clinician, right? And I think Dr. Mattson and I could both speak to this as, bedside nurses. Um, we've all been in that space, right? Where you don't know what to say. You don't know how to support your patient, and it's really unsettling. And so I just thank you for kind of highlighting that. And what I'm hearing too is this, it's not a lack of caring, right? It's a lack of preparation and a lack of guidance on what to do and what to say. So, Dr. Mattson, how do you see this lack of confidence showing up at the bedside and what's the impact like for patients as well as for staff and clinicians?
I think we can usually see it in the pace and the wording. So, when healthcare staff feel unprepared to address the emotional aspects, the visit can become very task driven. So, the focus would be on the labs and ultrasound and discharge without really naming what the patient is going through.
Mm,
And for many patients, this is the first moment that their loss is really addressed. So, the emotional meaning is front and center, even if the environment isn't built for it. So, when supportive language and clear communication are missing, patients often leave feeling confused and alone. And on the healthcare side, that uncertainty of not knowing what to say or afraid of saying the wrong thing adds stress and an emotional burden that can really be carried beyond that shift.
absolutely. Yeah, thank you so much for sharing. And I think I'm hearing, of course, the impact on patients, and we're going to get into this as we move through our time together today. So I don't want to take away too much from what's to come, but we know there's a huge impact on our patients. But what I'm hearing too is the impact on providers, right? And the toll that it takes. And I can only imagine how that adds up shift after shift, right? And um, kind of what you spoke to, Dr. Berry, as well, of not feeling, there's something missing in the care that you're delivering as a clinician, but you don't really know how to bridge that gap, right? And so going home at the end of that shift and you're just left, you know there's a gap and you don't know how to close that. And so I really appreciate that, Dr. Mattson, and it's what drives us right at the Institute, and it's why I'm so passionate about this work is that's the gap that we're trying to close. And I want to just kind of zoom out. So we've talked a little bit about the impact on patients and providers, but let's zoom out and look at why miscarriage care in the emergency department is so complex and why it's so challenging in that setting. So your study, and again, I hope everybody has a chance. If you haven't already, please read their study. They highlight in it that nearly 900,000 emergency department visits every year in the U.S. involve early pregnancy loss. That's staggering, right? Yet we know that emotional and psychosocial needs are frequently unmet. And like I said, I want to take a minute and look at kind of the scope of this. So, Dr. Mattson, if you would just kind of help us understand and describe for us why is the emergency department such a critical and challenging setting to provide care for miscarriage and early pregnancy loss patients?
So the emergency department is important because it's often the entry point. So people come in, they're scared, they're bleeding, they're uncertain, and then they may leave with this life-changing news in just a few hours. So that makes the emergency department one of the most influential settings for how this loss is understood and remembered. And it's challenging because the emergency department is designed for rapid triage, constant prioritization, and privacy can be limited. But even within those time constraints, how we communicate and plan a discharge can really change the entire experience. So if the patient hears clear, compassionate language and really leaves with a concrete plan and resources, that really matters even after they walk out the door.
Absolutely. And I think, again, you're just hitting the nail on the head, and there's so much there. I love that you spoke to some of the constraints, right? So time is a big one. Lack of privacy is a big one. And we would be remiss, right, if we didn't talk about these things. We know that it is a challenging environment to provide this care. But I really appreciate you kind of highlighting the fact too that it's not just a stop along the way for this patient, right? This is the point in their care where they're receiving the bad news, most likely, right? This is the point when they're confronted with this reality that they never expected. This was never a part of the story that they imagined for themselves. And if you can kind of put yourself in that patient's shoes when all of that is running through your mind in this fast-paced environment, like you're describing, and you don't receive clear communication, right? And you're scared and you feel alone and you're not sure what to do with this grief, how that could spiral, right? If it's never addressed. And so I would love to thank you for answering, Dr. Mattson. I would love, Dr. Berry, if you could kind of walk us through what does the literature tell us about the consequences of unaddressed reproductive grief? What does that look like long term?
To look at the literature and really understand the context of it, it's important to understand that reproductive grief is its own unique subset of grief. It's different than grief experienced by someone losing a spouse or a parent or even an older child. So, because this grief is so unique, it's often misunderstood. A lot of people don't really know the depth of it or how it differs. The
Mm.
other unique thing about miscarriage is that society in general, they have not developed a relationship with the life that has been lost. It's just the parents. And if there is not that social support, it's very difficult for those grieving to move forward in their grief and heal.
Mm.
As a whole, society, the human species has endured grief throughout the entirety of our existence, and we know how to heal in our grief. But key to that healing is going to be social support, which comes not only from the healthcare community, but from society at large. And
Mm.
what's unique about the reproductive loss is because society has not developed a relationship with that baby, then that loss is not special to them. It's not meaningful to them. And it's often unacknowledged. And when a loss is unacknowledged, that removes parents' permission to grieve. If they're not allowed to grieve, then all of that which they're experiencing internally, it stays there. It can't be expressed and let out. And what the literature tells us is that when grief is internalized, it is worked into our very are worked into us at a very cellular level. It changes our body, our physiology. And as it's continued to be unaddressed, it manifests as multiple chronic health conditions such as cardiovascular disease, endocrine disorders, immune disorders, sleep disorders. There are mental health manifestations, depression, anxiety, post-traumatic stress, suicidality, substance misuse, disrupted parenting, dissolution of relationships. It's honestly terrifying,
Mm.
the list that goes on in how disruptive this unaddressed grief can be if individuals don't have the support and the tools that they need. If they don't have their loss acknowledged, then their health outcomes can be very poor in the long run.
Thank you for walking us through that. And just as you're kind of sharing the list and the host of long-term, really can be lifelong things that come out of unaddressed grief, I'm sitting here thinking we have to do better, right? Like, how can I, as a clinician, or how can I, as a nurse, or whatever your role is, how can we support our patients so that this is something that, on top of the grief, they're not dealing with, right? And I think, yeah, there's so much, there's so much there, and I do want to highlight again in your study, you use the term emotional emergency. And that's a term that we at the Institute often employ to kind of give some color to what a patient might be experiencing, right? If you work in the emergency department or in healthcare at all, you're familiar with, right, physical emergencies, of course. We are taught how to treat them. We don't often receive training on how to respond to an emotional emergency, but I think that phrase can be really helpful to frame this experience, right? As we're looking at our patient who's going through a loss, who's experiencing a miscarriage, in whatever setting, but for today's purposes, in the emergency department. And now, as you're describing kind of the long-term effects of not addressing this loss, um, I think it leads to a question that probably most of us are asking ourselves, and that is, what can we do differently? How do we address this loss so that our patients have the tools and the permission to grieve and to adapt to the loss? Um, and I just, yeah, I'm thinking just given, we've spent some time talking about the scope of this gap, right? And its effect on not just patients, but on clinicians as well. Um, I would love, Michaeline, for you to kind of walk us through, again, what we as clinicians can do differently, and specifically the educational intervention that was studied. How is it designed in a way that's going to be supportive of an ED environment as we look at caring for our patients?
Yes, yes, certainly. And certainly we need some good news, right? That we are able to make a positive difference. So, Dr. Berry, can you describe the theoretical frameworks that guided this work?
Yes, and along the note of good news, is that the theoretical frameworks guiding this work are not brand new. They're not unfamiliar. They are things that nurses and healthcare professionals already embody and are familiar with. So, one of the concepts is the concept of companioning. And while that word might be unfamiliar, the context and the act of it is familiar to clinicians and nurses in particular. So,
Mm.
companioning looks at a grief experience and recognizes that grief is not a pathology. It's not something that needs to be fixed. It's not something you give a medication to, you change a dressing, and it'll go away. And in understanding that, the healthcare professionals can, rather than coming with approach of, I know what you need, I will tell you how to fix your grief, they will come with an approach of, I am here with you in your grief. I am a companion in your grief, and I will sit here, I will listen. I'm not here to fix you, I'm here to be with you. And being with is one of the core tenets of the nursing profession. I speak of the nursing profession because that's my background. But some of the other things are things like warden's tasks of grieving. Grief is work, and it is something that can be worked through and can be healed. And things like helping build enduring memories or intentionality, these are some of the practical things that can be implemented in the healthcare setting that, to Dr. Mattson's point, don't take a lot of time. We are constrained with time, but how can we use the tools and resources we have in this new light, in the idea of providing care for those experiencing miscarriage, and the idea of trauma-informed care, and recognizing that there are critical milestones in which the healthcare professional can intervene to set parents on a healing trajectory and help to avoid traumatizing or re-traumatizing those who are experiencing that. So again, it's really familiar concepts. It's things that we already do as clinicians. It's just applying it to the experience of reproductive loss. And so often we think this, I don't have the algorithm for this, therefore I don't know what I'm doing, but really that's not true.
Yeah. Thank you, Dr. Barry, for giving us the framework. And I think now thinking, let's, if you could you give us a couple examples of how you would take that framework and then how does that show up at the bedside?
Yeah, absolutely. So communication, and again, that presence and being with. So the first thing with trauma-informed care is recognizing the prevalence of trauma and the impact of interactions on traumatizing and re-traumatizing. Recognizing that reproductive loss can be an emotional experience and even emotionally traumatic for those experiencing it. When we recognize that, we can respond accordingly. So the first step, recognize. And then in the responding accordingly, remember that it's not something to fix, that you're there to be with them. So rather than focusing on just those tasks, like Dr. Mattson said, or like what I did in my practice before I knew this, just ignoring it, acknowledge it, recognize it, and verbalize, I wish you weren't experiencing this. Uh, just asking them, is this a loss that is impactful to you, or how are you doing with this? Because it's not wrong to ask someone if they're okay. Like that's what we're here for in our profession. So simply saying, are you okay? Can I sit with you? Even if it's for 10 seconds, that can make such a meaningful difference to those families. And then they have a positive note to anchor to as they are moving through their experience.
Yeah, thank you. That's all really meaningful. I was, as you were saying that, I was thinking how, in our culture, these losses tend to be disenfranchised
Mhm.
and 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 so there's almost kind of like a get over it or we're seeking closure. But as you said, it's not about closure. We know that Dr. Warden talks about adaptation. But part of that is what you're just saying, giving permission to do that, normalizing that experience, and then they're really knowing they're not alone and there's somebody there to support them. So thank you for giving that example. And actually, I'm actually gonna jump to you, Elsa, if that's okay,
Sure.
because I'd like to pose you a question to you because you're so intimately involved with developing institute programs. So I think it would be really helpful to talk about like how were these principles operationalized in the education program?
Sure. Yeah, it's a great question too, because I think um, they were intentionally designed to, like Dr. Berry's talking about, these are things that, and again, I'm a nurse, so I'll speak from the nursing perspective, but in healthcare in general, we learn things. we might learn principles or concepts or theories. And it's one thing to do that, and it's a totally other thing to practice them, right? And so our education was designed, there is a didactic portion. So that might be like an on-demand course. It could be a live lecture format. And that is where these concepts are introduced, right? Giving people a chance to learn them, to digest. But it's not much more than that. It's knowledge based, right? Um, but there is another piece to our education that is um, designed to encourage practice change. And that is a mixture of there could be case studies that are given, and people are asked to pair off and discuss kind of how you would approach a patient in that way. And then there's also, we do role plays, which would be taking a case study and actually assigning a couple roles to people in that setting. So if it's an emergency department, it would be nurses. It would be somebody playing an ultrasound tech. It would be somebody playing a receptionist, probably somebody playing a physician or a PA or a nurse practitioner. Could be somebody from the lab. So you get the gist, but we are assigning roles as a patient would encounter people in their journey through an emergency department. And we are allowing participants to really play it out as it would actually happen and giving them a safe place to practice these principles and to practice having these conversations. Because as you heard from Dr. Mattson earlier, the emergency department, it's such a high intensity setting. And the stakes are really high, right? When you have a patient in front of you. And so doing these role plays in a safe place allows clinicians the chance to practice the language and practice these approaches that, to Dr. Berry and Dr. Mattson's points, they don't necessarily take a lot of time, but we do have to practice to be able to hone those skills, to be able to companion with our patients, and to be able to move away from this treatment approach that we are taught in school and more into this companioning approach. And and yeah, that's a little bit about kind of the model that we use.
Well, I think that really helps our participants to know like what exactly, what exactly are we teaching? Because we're going to go into the results of that. And so the overview is really helpful. I also think, of course, we have, well, there's three nurses here today, but our program is beyond nurses. We know nurses have a critical role, but as you just talked about, Elsa, this is a whole team. I know when I'm teaching, I like to say, well, grief care is whole person care, and whole person care needs a whole team to do it. And not only do we bring our own areas of expertise, but it does help to solve the time issue because we can put all our minutes together and it can create this very different experience. So, thanks for giving that context. And I just wanted to again create a little bit more context. And that is once this educational framework was put into practice, the Institute team, in cooperation with Scripps Health, wanted to understand whether it actually made a difference. So, not just theory, we wanted to see was there an improvement in clinicians' confidence and care behaviors. And so, with that in mind, Elsa, I hope you can guide us and take us deeper into the results of the study.
Yeah, thanks, Michaeline. I'm excited too. And I'm very excited that we have Dr. Mattson with us because she is brilliant in all things statistics, and just her mind is blessed in that way. And I am not. So I'm excited to have her share her expertise with us. And so, with that, Dr. Mattson, if you would, let's discuss your findings. If you could just talk us through what outcomes you observed.
Yes. So, to give a little bit of background, the education was provided. There was a pre and post test. So, the staff was surveyed and they were asked questions about their knowledge and comfort on the following areas. So, emotional support, patient-centered care, discharge planning, bereavement care, community support, supporting staff, and communication skills. And this included a variety of profession and healthcare staffs within the emergency department. And we saw statistically significant improvements across all 7 domains that we measured in the education in the matched sample. And every domain, the p-values were less than 0.001. And what I take from this is when you give healthcare teams really practical tools And the shared language, case-based learning, multidisciplinary training, with really a clear framework, you can shift how prepared people feel to deliver this psychological care alongside the medical care in these really highly sensitive areas.
Thank you so much for kind of walking us through that. And um, I, again, not a statistician, but I think it's so striking that 7 domains showed statistical significance. Um, that just makes me kind of sit back for a second. And it also makes me curious, Dr. Mattson and Dr. Berry, I'd love to hear from both of you, have you chime in, but of those, so you went through 7 domains for us, Dr. Mattson. Of those 7, which feels most meaningful to you as a clinician beyond just kind of your research lens?
So, yeah, they were all significant, but the changes in emotional support and communication were particularly meaningful. And I think these areas directly influence how patients experience their care, their miscarriage care. Also, bereavement care was highest, but the Cronbach alpha was low there. So, this really shows us that we need to support this area and find better ways to measure grief and bereavement in this context.
Thank you so much. Yeah, and that's, we'll get to that in a little bit, but it excites me to think about other areas of research and kind of how we can build on this foundation and just look even deeper. Dr. Berry, would you mind sharing too, just any insights, anything that you found most meaningful out of those 7 domains?
I found the confidence, that increased confidence with that knowledge to be I this sounds so cliche, but knowledge is power. And a lot of the
Yeah.
discomfort from my own practice, from the nurses I've talked to, from the literature that I have reviewed, it's that lack of knowledge that really is the key thing. And how do we provide this care? And if you're not confident in the care you're giving, you're going to shrink away from it and you're going to avoid it and you're going to try to pretend like it doesn't exist. And at the end of the day, that makes me at least feel like a terrible nurse and like I've done a disservice to my patients. And
Mhm.
so really just that significant increase in confidence made me grateful for those nurses who are out there practicing, and then grateful that there is something that can really empower healthcare professionals to provide care that they feel good about and that can support families experiencing loss.
Yes. Thank you so much for sharing. And I do want to highlight, I think, I don't know what you said that made this jump out for me, but I think too, to how disappointing it can feel, right? When you don't feel confident and you do, like you said, shrink away from that care. And then I'm reminded too of like this framework that we're presenting. And I just want to remind everyone in the audience too that it's what we're talking about. No, nothing is resting alone on anyone's shoulders, right? This is a multidisciplinary approach. And so I don't know. I just felt like I wanted to say that and speak to if you're feeling like this feels really heavy and it's a lot for one nurse to bear, right? The responsibility of that. That is not at all what we're suggesting. And that's kind of the beauty of this educational intervention, right? Is that we're involving a whole team. And so when we're measuring confidence across a whole team, if you can imagine that patient is receiving confident, compassionate care from all of these different touch points, that's the consistency and the trauma-informed care that can totally change an encounter. So thank you so much for sharing. And now that we've heard from Dr. Mattson and Dr. Berry, we're going to put up another poll. We would love to hear from all of you who are participating and listening. There are the 7 domains up on the screen, and you can choose 3. We would love to know which feel most meaningful to you. So I'm going to be silent for a little bit and let you select your 3, and then I'll give her the high sign and Michaeline will share the results with us. And okay, I think hopefully everyone's had a chance to kind of click their 3 options.
Yeah, I'm going to give just another couple
Okay.
seconds because I'm seeing people rapidly
Okay.
making their
Perfect.
choices right now. Maybe because we let them choose up to 3 on it. Okay, it
And
looks
there's a
like it's,
lot there, so
yeah, it looks like it's slowing down just a tad. So I'm going to end the poll right now. And of course, people, they can add their thoughts into
yeah,
chat
put them in
as
chat.
well, right
Yep.
along the way. So.
Okay, let's see. Okay, so emotional support, really high. Looks like emotional support, bereavement care, and patient-centered care um, stood out to all of you as probably the most meaningful, which is really, sorry, I'm reading through these. There's 7 domains, and I'm like, where did everyone land? No, that's really interesting. And
Yeah, I see high for communication skills as
yeah,
well.
that one too. Thank you, everyone, so much for taking a minute to reflect and just to kind of think honestly about your practice and what stood out to you. So I know, again, if anything jumps out, please continue to kind of put that in the chat. Or if you have questions about any of these domains or um, kind of how that was measured, maybe feel free to put that in the Q&A. We're going to have time at the end to kind of walk through some specific questions. So with that, I would love to kind of redirect. And Dr. Mattson, I will go to you. If you could just share a little bit about what stood out to you regarding the feasibility of this study.
Feasibility really showed up in the interdisciplinary participation. So this wasn't just nurses, it included ED techs, chaplains, social work, radiology staff. And this matters because the miscarriage care touches on multiple roles and patient experiences as a team. So not just a single provider. And also the training was designed to be, a mix of usable lectures, case studies, role play, and then to see how staff responded to that training. And this combination is important because it's not just the receiving of information, but it's also that rehearsal for these really emotional, intense conversations. And this also demonstrates how educational interventions for psychological care can be implemented in really busy areas, such as the emergency department, to then start improving this area.
Thank you, Dr. Mattson, for sharing. And I'm just, yeah, it is, I think with everything we've talked about, right, the multidisciplinary approach, it is really, really encouraging to know, Dr. Berry, I think you mentioned this too earlier, but it's really encouraging to know that we can impact confidence, right? And that obviously more research is needed when it comes to like patient outcomes and results, but it is so encouraging to know that we can improve the confidence level of care providers and not just nurses, like we're saying, it's a whole team, right? And it takes a whole team to care for patients and to provide that consistency. And that is what, when a patient can move through the emergency department and be met with that compassionate language, the compassionate care, the companioning at every encounter, it transforms the experience, right? And it does, like Michaeline mentioned earlier, it gives them permission to grieve and it enfranchises that loss rather than kind of contributing to that isolation. And so, yeah, I just have to say that really encourages me um, that we saw such high engagement across kind of the spectrum of disciplines. Um, Dr. Berry, question for you. Was there anything that kind of challenged your assumptions in the study? Did you, were there any results that surprised you? Yeah, or challenged your assumptions?
As any researcher knows, getting the data, especially if it's survey data or filling out a questionnaire, it's extremely difficult to get participation. So while there was a very large number of multi-professional individuals that participated in this intervention, only 39 in total surveys could be matched and used in the analysis. So before we got our results, I was writing the limitations in my head about how, it was a small sample and we're not able to, talking about feasibility. And
Right.
then when Dr. Mattson said, yeah, the results were significant, I was so surprised. And not only were they statistically significant, but with a p-value of less than 0.001. And while I am not a statistician, I am deeply grateful for Dr. Mattson's expertise. I do know that that's a big deal. So the impact that is able to be seen, even in the small sample of respondents, to me is what stood out the most.
Absolutely. And I join you in gratefulness for Dr. Mattson and also just in, again, how striking and compelling these findings really are. Um, so I think if you're like me, you're naturally kind of wondering, what does all of this mean for everyday practice? How does this translate? So, Michaeline, let's kind of explore how what we've just talked about can transition into real world change.
Yes, this is to me always the most exciting part. Now we're gonna do something here in this section because we want to make sure we have time for Q&A from the participants. So if you have questions, start putting those in the Q&A box because we're going to be getting to that next. And we're going to do what we fondly call at the Institute of Reproductive Grief Care a lightning round. So we're going to do like really kind of brief answers for this, but I'm excited to hear what they are. So, Dr. Berry, I'm going to start with you. What does embedding reproductive grief care into standard emergency department training actually look like on a unit level?
Okay, brief. To me, we already have standardized training and education we need to do to keep up our licensure and to maintain compliance. I know when I was at the bedside, if I didn't complete my learning modules, I wasn't allowed to work the floor until I did. So to me, it looks like just that's a structure that's already in place, recognizing the importance of reproductive grief education and implementing it in a practice setting.
Well, that was very brief. Did you want to add
I
any
do,
more?
actually, I
Come
really
on,
do.
honey, go for it.
Thank you. Because just like training for a code or making sure you're up to date on how to administer blood products or what to do when someone comes in with a stroke, we need to know how to respond to individuals experiencing miscarriage and reproductive loss. And we also need to know that the institution we work for supports us. And the institution and the leadership management, they're able to say this is a priority based on the care or the education that they require. So as I look at it, from my perspective, it seems very simple. Let's just assign a few healthcare or health stream modules to that. And not only does it say this is important, it says to the healthcare team, this is how we are supporting you in the important work that we're doing. And this is the tools that we're giving you so that you can provide high quality care that you are proud of and that really might lead to better patient outcomes.
Yeah, thank you. Thank you so much, Dr. Berry. And I know you're very passionate about this, and I really appreciate it and share it.
Hmm.
This one I'm going to pose to both of you, and well, actually everyone. So I'm going to pose a question, and I would love every participant to put your response in the chat box while we're listening to the responses of Dr. Mattson and Dr. Berry. And the question is, this is super practical. What small practice change could a bedside nurse make tomorrow based on this research? And let's start. And for those who are listening, we have some other, like it could be what small practicing could a chaplain or could, a tech or whatever it would be. Fill in the blank, put that in chat. And while you're doing that, I'm going to go back to you, Dr. Berry. What's one small practice change that a bedside nurse could make tomorrow based on this research?
I think really just the acknowledgement, taking the time to sit down, the 10 seconds to sit down and say, this is a difficult experience. How are you doing?
Hmm.
And allowing them to respond in whatever way that they choose to.
Yes. Dr. Mattson, what's one small thing you would choose?
I think it is being able to anticipate for the patient who cannot anticipate all the next steps and communicate that with them and the team. So even if they're not able to give that specific diagnosis because they need another ultrasound, to acknowledge that and say what is happening and a very clear delineation of it, and then having space for that emotional response and then following up from there.
Oh, thank you. And I was just thinking, I labeled those as small practice changes, but we know those changes can literally change that whole experience. It could change a life
Hmm.
moving forward from there. So thank you for sharing that. And I'm really excited to later on, I'm going to sit down and read all of the responses from the chat participants. So thank you so much and kind of keep those coming in.
Yeah.
And then my final question, I think, before we get to Q&A, again, I want to pose this to both of you. It was already hinted at, but let's talk a little bit more about where does future research need to focus? Dr. Mattson? What do you think?
Yes, so this study was very foundational in looking at the educational framework and training. I think next steps are to go towards that patient side of things, to start to research it from that perspective and let that perspective then inform practice change as well.
Okay, and Dr. Barry.
In line with what Dr. Mattson said, looking at the patient side and looking at, is there an impact on the chronic outcomes of grief, the cardiovascular disease, the endocrine disorders, depression, and anxiety? Look and see if trauma-informed care is implemented. Does that change anything? We already have the data and how the significant health burden that this can have if patients experience disenfranchised grief and complicated grief. Now we need to know, what do they experience when there is high quality reproductive grief care provided.
Well, wonderful. I hope the two of you are going to be involved in studies like that. And I hope that you've inspired some of our participants. In fact, I'll just put a little plug in. We do a lot of different research with bringing researchers together. So if there's any interest, please reach out to us.
You've
But
come to
with
the right
that,
place.
yeah, Elsa, would you lead us through a time of Q&A?
Yes, I'm so excited too, and I'm seeing some questions here, but I'm gonna kind of start us off, but please keep putting your questions in the chat. Um, I just want to say, first of all, this has been such an enlightening, but really such an encouraging conversation and discussion. So thank you, Dr. Mattson and Dr. Barry, for what you've shared with us, and thank you everyone for participating. I'm excited to move into Q&A, but I could just spend hours here picking your brains. So we talked about evidence, we've talked about application and what's possible moving forward, and we really want to hear from you all. So we're going to move into a time of Q&A as promised. So please keep putting those questions in the Q&A box. I'm going to start us off with a question, and this is for both of you, both Dr. Mattson and Dr. Barry. So whoever wants to start, but what would you say to an ED clinician who worries that they're going to say the wrong thing to a grieving patient?
I'll jump in.
Yeah, you take it.
Okay. Often, if we're afraid we're going to say the wrong thing, we keep silent. And that silence disenfranchises the grief experience. And it communicates to the individual experiencing the grief that their grief is not legitimate. And so I would just encourage that clinician to be brave and be transparent. If you start out with, I don't know the right thing to say, but I see this as difficult for you, just let them know I'm here to help you. If you don't know how, you don't know how, but just opening that conversation and acknowledging, don't let that fear prevent you from really, truly being with the patient.
Thank
Yeah.
you.
Thank you for that. And actually, Dr. Barry, I want to actually ask you another question that came in from one of our participants, because I know that you have some specific thoughts about this. And so Robin is asking, can you address ways to get hospital administration to buy into providing this education to staff, and traditionally staff who will attend if paid to attend?
Yes, and that's a great question. And I do get very passionate about this. The hospital system is a business model, and there is no way around that. It's all about the dollar sign. If there aren't the dollars, then that healthcare system is going to have to close its doors. And so we need to, as nurses, as chaplains, as social workers, we need to speak the language of the business administrators who are in their leadership roles. And we can say, the evidence is here. The long-term outcomes and burden on the healthcare system is very evident. It increases healthcare utilization, pharmaceutical utilization, increased missed days of work, not only in the community, but in the health field as well, because clinicians are experiencing their own losses. We are not outside of those statistics. Like, we are those statistics as well. So looking at it from a dollar standpoint of saying, this is a way that we can decrease the health burden in the healthcare system, looking at it from a viewpoint of, this is how we support staff. And with this education, we can empower our staff to provide the care that our patients need. And that is going to help with burnout and compassion fatigue and moral distress. And by providing solid patient care, we can have a reputation of a healthcare system that really takes care of its community and understands its community needs. I could go on so much longer, but I want Dr. Mattson to have time to chat it in.
Okay.
Thank you so much. I feel like your enthusiasm is contagious and we can feel it. And I appreciate it so much because this is, I mean, it is life-changing work. And I just really appreciate it. I'm looking through the Q&A and I just lost it. I do want to mention this one. Somebody asked, would the curriculum address nursing students or other medical students who have experienced a death of their infant? And I want to kind of broaden this, like in general. I know you can obviously answer that question too, but what type of resources, what do you hope for education for nursing students or medical students as they're kind of in this in between, right?
I can take this one. So I think the first step, there's two things. I think one is that the education needs to be integrated into accreditation standards. And I think the schools right now, what we do is we teach to whatever our student learning outcomes are. We match that so that it fits within the AACN or whatever accreditation body is overseeing that institution. So I think there needs to be a clear connection too between that uh, perspective and the curriculum. And I think that will allow for this to be then addressed within the curriculum, is to have it also addressed in the accreditation standards. There are other innovative ways to approach this. So at San Diego State, there is a course that is interdisciplinary. So they pull students from, from social work, nursing, public health, and they do a course together. And it's new, it's just being developed through Health and Human Services. And I think integrating innovative courses like that one, where people are getting education that's interdisciplinary from the beginning, or have minors and majors that have this interdisciplinary focus, will allow also for this kind of education to be matriculated into it in a more holistic approach.
Dr. Mattson, thank you so much for bringing that up. That's really, I didn't even know that. That is so
Yeah.
encouraging. And I've heard of a couple other instances where you have medical schools or other programs looking to, and I can only imagine how that will kind of transform healthcare across the board. So that's really exciting. There's another question, Dr. Barry, that was kind of goes on to the last question you answered. And this is asking, for departments who are interested in adopting, so they heard your plea and they want to adopt this type of education, what advice would you give them for getting started?
Yeah, that's a great question and a practical question. Thank you. Um, the big thing is getting that leadership and management buy-in, because once you have that institutional support, it's much more successful. So there are courses available on HealthStream. There's obviously the Institute that offers online modules, and also person-to-person training and the live webinars. So the big thing is having a plan, saying, this is what we need, this is the resource we want to utilize, and this is how it's going to work. And bringing that forward and getting buy-in from the staff as well. Find those people who are in your corner, who are very passionate about it with you, and don't take no for an answer. Just keep pushing until you get the resources that you need.
I think I see something in the chat along those lines that says sometimes a really busy ER doesn't have the staff or time to deal with a pregnancy loss. It would be helpful to establish a pregnancy loss committee for special training, have a pregnancy loss champion available on every shift. And I think to your point, Dr. Barry, that's a beautiful example of a place to start, right? Um, and I
Absolutely.
love,
And I'm going to add on to that,
yeah.
because it's so good to have that champion. It's fantastic. And take care of that champion, because often they're the one dealing with all of them, or caring for all of those miscarriages. And that can be taxing. So, those champions out there, take care of yourself and have a champion buddy. And
Mhm.
just be careful with that, because the work, it's so rewarding, but there is a personal cost to it. And it's important to take care of yourself.
Yeah, thank you for mentioning that. And I hope that goes for everyone on this webinar today. The work that you all are doing, this work is so beautiful, but it is so heavy. And so that is a plug for all of you, right? To take care of yourselves and just be mindful of how you're doing. Um, I'll ask one more and then I'm gonna let Michaeline wrap us up. But I'm curious, for both of you, so let's say we've kind of moved through like how can you get started, right? If you want to implement this, how can institutions who have implemented this or are doing this work, how can they measure whether reproductive grief care education is truly changing staff culture, or patient outcomes over time? What would that look like?
There's a few different ways I think that this could be approached. One, it could be done, through surveys, right? Surveying the staff. It could be done through interviews, asking those questions. A lot of hospitals have unit-based councils and they look at quality improvement measures and they have specific standards and approaches that they use to measure and chart, the progress on that. So I think any of those would be kind of practical ways to look at it.
Hey, thank you. Thank you, Dr. Mattson. All of those are really great ideas. And we do want to measure, right? We want to know that we are truly making a difference. I'm going to end with one last question before we go into wrap up. I know some of you are eager to be able to get your contact hours roll, and we'll talk about that. I'm going to do this like a really quick ask each of you, Dr. Mattson and Dr. Barry, what gives you hope about the future of miscarriage care in emergency settings?
I think the fact that there were three large healthcare systems in San Diego willing to implement this intervention and participate in this study is what gives me the greatest hope. There has been institutional buy-in there, and they are innovative leaders in this. And if they started, like Dr. Mattson said, this is the foundation, and often that first movement of that giant stone up the hill is the hardest to get, and it started.
Hey, Dr.
Uh,
Mattson.
Yeah, I think right now it's seeing all the responses in the chat and knowing that people are out there and that they care about it and they're doing this too. And everyone here is very innovative. And I think if all of the healthcare multidisciplinary groups here that are present go out and continue this or are interested, that gives me a lot of hope.
Oh, that's beautiful. I love that. And I want to thank both of you, Dr. Barry and Dr. Mattson, for conducting this study, and for sharing your expertise with us today. Thank you so much.
Thank you for having us.
And I also want to thank the leadership and staff of Scripps Health San Diego and Chula Vista campuses for participating in the Institute's Emergency Department program, which became the site locations for the study that we were discussing today. And I'm happy to report that the program continues in these locations with ongoing reproductive grief care education and integration of best practices. So, and then of course, all of you, my goodness, we couldn't have done the webinar with all of you participating today. And I just want to honor the work that you do. And so before you sign off, we really want to get your feedback. So please take a moment to complete the evaluation. The link is being put in your chat right now. And of course, completing this evaluation is required to receive your contact hour. But like whether or not you're interested in that contact hour, we are really interested in your feedback. It's very valuable to us. It helps us to continue refining and tailoring our education, and it truly supports clinicians who are caring for patients during these profound moments of vulnerability that we were discussing today. If you are interested in this education and want to learn more, we'd love to schedule a brief call so that we can learn more about your needs and then answer any questions that you may have. I believe that Scott's email is being put into chat as well, and you'll also get that in our follow-up email. And then finally, as we part today, I want to invite all of us to take one small intentional step. So let's reach out, whether it's today or sometime this week, to someone who's been personally impacted by reproductive loss and offer our words of acknowledgement and support. As we all know, compassion doesn't require perfect language, but it does require us to be present. And Elsa, I want to thank you for co-hosting this conversation with such care. And of course, again, to all of you, thank you so, so much for the work that you do, for the compassion that you obviously bring, and for the difference that you're making, often in quiet, unseen ways. Thank you so much, and I hope that we'll be able to interact again in the future.